Kirsty, you can start sharing your screen and we'll start in a minute.
Sure.
Okay, good afternoon, everybody. Today, we are going to discuss a big topic, congenital diaphragmatic hernia. And initially, Dr. Pedersen will talk about the basics, including embryology, pathophysiology, etc. And then Dr. Nahaus will talk more about the surgical aspects. So I think without wasting much time, we can start with Kirsty. Kirsty, you can go ahead, please.
Okay. Good evening, team. So as Prophet said, I'll be touching on a small introduction, a main focus on all the different embryology parts that are involved, and then the pathophysiology linked with that. I'll briefly touch on anatomy just because of time, and then clinical presentation and investigations. So congenital diaphragmatic hernia remains a congenital anomaly with 20 to 30% mortality, significant morbidity, and long-term disability. It was earliest described in a newborn in 1754, and then further described in the late 1800s. And the first successful repair in a child was done in 1905. So with CDH or congenital diaphragmatic hernia, there's varying degrees of severity. Approximately 1/3 of babies born with CDH are stillborn due to associated conditions. The prevalence is estimated around 2.3 to 2.4 per 10,000 live births. I couldn't find any articles with the prevalence in South Africa. The only study that gave an indication of the numbers that we see was one that looked at infants admitted with CDH to NICU at Tygerberg Children's Hospital over 9 years. So they saw 40 neonates over those 9 years. So looking at the embryology, we'll first look at the embryology of the diaphragm. The septum transversum is a thick band of mesodermal tissue that separates the thoracic cavity and the stalk of the yolk sac. You can see that on the left. There are large openings on either side of the septum. These are called pericardio-peritoneal canals. They run on either side of the foregut. Around the 5th week, the periperitoneal folds developed, and these project into those canals. By the 7th week, the periperitoneal folds fuse with the mesentery of the esophagus and the septum transversum. You can see that in B in the middle. This then closes the connection between the pleural cavity and the peritoneal cavity. And then at 4 months, there's expansion of the mesenchyme of the abdominal wall. This forms a rim around the pleuroperitoneal membrane and the septum transversum. And then myoblasts from C3 to C5 penetrate this membrane and then form the muscular part of the diaphragm. So if we look at it as embryological and then postnatals, the septum transversum forms the central tendon. The pleuroperitoneal membrane forms the dorsolateral parts of the diaphragm. Thoracic intercostal muscles will form the muscular part. And then the esophageal mesentery forms the dorsal crura. Looking at the embryology of the lungs, the fetal lung development is divided into 5 stages. First stage is the embryonic stage. This happens around 4 weeks, same time as the diaphragm starts to form. There's a respiratory diverticulum, also known as a lung bud, that forms as an outgrowth from the foregut. Tracheoesophageal ridges fuse to form the tracheoesophageal septum. This separates the esophagus from the trachea and the lung buds. And then around 6 weeks, lobar structures develop and the lungs expand into the pericardioperitoneal canals. The second stage is a pseudoglandular stage. This occurs between the 5th to the 17th week with the formation of the formal lung bud and the main and terminal bronchi. Secondary bronchi divide to form segmental bronchi on the left and on the right. So third is the canicular stage. This happens between the 16th and the 25th week. This is where the pulmonary vessels, respiratory bronchioles, and alveolar ducts begin to form. So it also has their from this stage onwards, functional gas exchange is now possible. Fourth stage is the saccular stage. This happens around 24 weeks to term. It's the maturation of the alveolar sacs. Airway dimensions and surfactant synthesis capabilities continue to mature as well. The last stage is the alveolar stage. This occurs after birth with the continued increase and development of functional alveoli. There are further 6 divisions of the bronchial tree that happened after birth. It's estimated that only 1/6 of the adult's number of alveoli are present at birth. The remaining alveoli are formed during the first 10 years of postnatal life. The fetal circulation. So on the left of your screen is the fetal circulation, and on the right is the postnatal after birth circulation and the changes that happen. In CDH, the persistent fetal circulation is part of the pathophysiology that we'll get into, so I just thought I'll touch on it. So as a fetus, the pulmonary vascular resistance is high. There's very little blood flow that goes to the fetal lungs. Only 7% of the cardiac output goes to the lungs. The fetus shuns blood from the placenta via the foramen ovale and ductus arteriosus into the systemic circulation. So this is a right to left shunting. At birth, when the baby starts breathing, the pulmonary vascular resistance drops, causing a decrease in pulmonary artery pressure and an increase in pulmonary blood flow. The systemic vascular resistance rises, so there's an increase in left atrial pressure. This causes closure of the foramen ovale. And then the increased arterial oxygen tension from breathing leads to spontaneous closure of the ductus arteriosus. Persistent fetal circulation may develop if this whole process is interrupted. So in CDH, there's increased pulmonary vascular resistance, causing an increase in pulmonary artery pressures and decreased pulmonary blood flow. There's then that right to left shunting of blood by the foramen ovale in the atrium or by a patent ductus arteriosus continues in a persistent fetal circulation. This results in unsaturated blood entering the systemic system. Then this slowly becomes more progressive. So as more of the blood mixes with desaturated blood, the child becomes hypoxic. Hypoxia causes it, and then the whole cycle just continues and worsens. In CDH, there's also failure of the normal arterial remodeling that should be happening. And then, as I mentioned, hypoxia, acidosis, hypothermia, and stress can stimulate pulmonary hypertension to develop further. This is then mediated by the prostaglandins, catecholamines, and the renin-angiotensin system. So then looking at the pathophysiology of CDH, during development of the diaphragm and the midgut, during the development of the diaphragm, the midgut contents are herniated into the yolk sac. If closure of the diaphragm is by the 9th to 10th week, then the midgut contents herniate through a defect into that thoracic cavity when the midgut returns to the abdominal cavity. Non-muscularized membrane may form, which can then form a hernia sac in about 10 to 15% patients. This defect is normally established around 12 weeks. And then you can also have the effects of the herniated organs that are herniated into the thoracic cavity. So the herniation of the stomach and the bowel results in the abnormal position of the bowel, incomplete rotation, as well as abnormal fixation of the bowel. If the stomach is herniated, it causes obstruction at the gastroesophageal junction. This results in dilatation and ectasia of the esophagus. If the right lobe of the liver is contained, the hepatic vein may drain ectopically into the right atrium. There might be a fibrous fusion between the lung and liver. This is important when you try to repair the defect. And if a kidney herniates, it might be tethered by the renal vessels, causing vascular compromise to the kidney. So pulmonary development is affected bilaterally in CDH. It occurs more on the ipsilateral than contralateral side. The herniation occurs at the time of the bronchial subdivisions. Therefore, all major lung buds are present, but the number of bronchial buds further is greatly reduced. There are very few alveoli that develop. There's an increase in the muscle thickness of the airways, as well as a reduction in the total number of arterial branches. There's adventitial and medial wall thickening in the pulmonary arteries. This causes an increased risk for pulmonary hypertension. It seems that the pulmonary veins seem to be spared in CDH. So there in the picture, you can just see that sort of compressive effect of the herniation into the thoracic cavity. So there are many theories around CDH and around the cause of CDH. It's yet largely remains unclear, and currently it's thought to be multifactorial. We don't know the exact cause as such. The advanced understanding of this has been halted due to a lack of acceptable experimental subjects. So it's very difficult to replicate the defects in rats or etc. So some theories around the failure of closure of the pleuroperitoneal canals. It might be due to the progressive growth of the pleuroperitoneal membrane that doesn't form correctly. The hepatic and adrenal organogenesis may play a crucial role. There may be the involvement of the posthepatic mesenchymal plate. This is currently a leading theory that they're looking into. And then the pulmonary development involves multiple factors, such as gene expression, growth factor interactions, and hormone levels. Abnormal levels of all of these have been found in babies with CDH. So they, again, looking further into what might be the exact cause. And then there's also the role of physical factors such as adequate intrathoracic space and the amniotic fluid dynamics that will play a role in the formation of the pulmonary development. So it's generally widely accepted that it occurs early in fetal development, as I mentioned, around the 10th to 12th week. However, some claim it may occur late in gestation or might be intermittently present as a dynamic process with sort of a sliding hernia effect. So continuing, the embryological basis of CDH again remains controversial. I'm just going to go through the three main theories at the moment. It was thought initially that the defect happened secondary to failure of different parts of the diaphragm to fuse, resulting in a patent pleuroperitoneal canal. Another speculation is that the lung hyperplasia might be the primary causal factor. So if development of the lung bud is disturbed, there's an impaired development of the posthepatic mesenchymal plate that is then closely related to the development of the lung. And this then results in the defective diaphragm. So this says that the initial insult occurs during the stage of organogenesis. of the lungs forming. And then this is then followed by the compression of the ipsilateral lung secondary to the herniation of the abdominal viscera at later stages. This theory nicely hyperplasia on the contralateral side that is seen with CDH. Be due to a genetically predisposed baby being exposed to environmental factors such as insecticides or drugs. And then lastly, that there's an evolving hypothesis that's due to alterations in the retinoid regulated target genes. This is due to clinical findings that babies with CDH have a vitamin A deficiency at birth. So again, it's a hot topic, a lot of research going into it. We'll have to see what develops. So looking at the anatomy, again, I'm just going to briefly touch on it since we generally know it, and we're going to try to keep short on time. So this is the diaphragm, it's double domed, it's the chief muscle of inspiration. The right is slightly higher than the left because of the liver. There are three muscular parts of the diaphragm, sternocostal and lumbar parts. The crura are musculotendinous bands arising from the anterior surfaces of L1 to L3. And then there's medial and lateral arcuate ligaments that form along the sides of those. This is just a really nice table from the Moore Anatomy textbook showing the arteriovenous and lymphatic drainage and innervation. The superior surface and inferior surface have different innervations, and the arteries and veins form the sort of branching pattern over the surface of the diaphragm. Arterial supply is mainly through the superior phrenic coming off the thoracic aorta, and then by the musculophrenic and pericardiophrenec arteries. And the inferior surface is mainly by the inferior phrenic arteries, again coming off the aorta. Venous drainage is by their companions, the musculophrenic and pericardiophrenec veins. These drain into the internal thoracic veins, and then superior phrenic vein, and finally into the IVC. Similarly on the inferior surface. On the inferior surface, the inferior phrenic vein might be doubled, with one half draining into the IVC and one into the suprarenal vein. Then lymph drainage mainly goes to parasternal, posterior mediastinal lymph nodes. Motor supply is from the phrenic nerves from C3 to C5 due to the embryological development. And then sensory supplies again from C3 to C5. Then next part of anatomy that's important is all the apertures. So the IVC runs through the cable opening around the level of T8. It also contains the terminal branches of the right phrenic nerve and some lymphatic vessels. T10 has the esophageal hiatus containing the esophagus, anterior and posterior vagal trunks, esophageal branches of the left gastric vessels, as well as lymph vessels. And then the right crura forms a muscular sphincter at the level where the esophagus passes through the diaphragm. Aortic hiatus around level T12 contains the aorta thoracic ducts and may contain the azygos and hemiazygos. And then lastly, just a few others. There's a small opening in the sternocostal triangle anteriorly. This transmits lymphatic vessels, as well as the superior epigastric vessels. And then the sympathetic trunk passes deep to the medial arcuate ligament, accompanied by the least splanchnic nerves. And then there are two small apertures on either side of the crura of the diaphragm. One transmits the greater splanchnic nerve and the other the lesser splanchnic nerve. Looking a bit at the epidemiology, it seems to be more common in male infants, more common in macrosomic babies or in babies with prematurity. So 23% are anterior, known as Morgagni. Central, the majority are posterior lateral defects, with 13% seen on the right and 85% seen on the left. These are Bartholek hernias, and then very rarely 2% might be bilateral. So looking at the Bolshevik, its CDH is caused there by the failure of those peritoneal membranes to close the canal completely. The classic CDH is a left-sided posterior lateral defect, normally about 2 to 4 centimeters in diameter. The bowel contents herniates into the ipsilateral thoracic cavity. This may also include left lobe of the liver, the spleen, entire GIT tract, stomach, or kidney. So on the top you can see a left-sided, and on the bottom a right-sided. So an anterior hernia of Magagni is less than 2% of CDH anomalies. It's due to failure of fusion of the crural and sternal parts of the diaphragm. It's usually large, occurs at the junction of the septum transversum and thoracic wall, where the superior epigastric artery normally has a hernia sac, may contain omentum, small intestine, colon, and rarely the liver or the spleen. It has a high incidence of associated anomalies such as Down syndrome or congenital heart disease, and then can be associated with the pentology of Cantrell. It's mostly asymptomatic as a neonate and presents as an infant with respiratory distress, recurrent lung infections, general epigastric discomfort, or vomiting due to intestinal obstruction if that develops. Normally diagnosed on a chest X-ray, which will show a air fluid level in the midline of the chest. And then you can, fluoroscopy or CT scan can aid in a difficult diagnosis. Then I just wanted to mention diaphragmatic eventration. That's due to the incomplete development of the central tendon. Due to phrenic nerve injury, due to mediastinal tumor, or congenital heart surgery, or birth trauma. So it's defined as an abnormal elevation of the diaphragm, which results in paradoxical motion during respiration and interferes with the normal mechanics and functioning of the lung. It can also be associated with Werder-Hoffmann syndrome. It's mostly left-sided, fewer bilateral. The diaphragm can rise as high as the third intercostal space, which I thought was quite drastic. It is uncommon that this results in lung hyperplasia unless they are particularly large, and does not commonly affect the circulation or pulmonary vasculature. Presents in a neonate with respiratory distress or recurrent chest infections, feed intolerance due to uncoordinated sucking and breathing. Then in an older child, it can present with exercise intolerance. On the chest X-ray, you'll see the elevated hemidiaphragm, or the Keiler-DT sign, which is the sign on the bottom right. The radiological finding of bowel that is then put between the liver and the right hemidiaphragm. Further investigation can be done by ultrasound or fluoroscopy, and then CT scan or MRI. So associated anomalies, approximately 60% of CDH cases are isolated. The rest of the cases have at least one additional anomaly. So a third of the patients with CDH will have a genetic variation. It has also been associated with over 70 syndromes. So those syndromes where diaphragmatic malformation is a predominant defect are Fryns and Denoy-Bowie syndrome, as well as Mitchum. And then CDH occurs in a very small percentage of the rest of these syndromes, but still the people with the syndromes are at risk. So that's the trisomies, and then as you can see, the Beckwith-Wiedemann that we know quite commonly, and a few others that aren't as common. And then otherwise, isolated associated anomalies, most common is cardiovascular, followed by urogenital musculoskeletal, and then NCNS. There may also be tracheobronchial tree defects or midline defects that are associated. And then just really importantly to note that the impact of these associated anomalies on the child's prognosis and the overall outcome for the child cannot be overstated. So CDH will always need to be managed and in a complete clinical picture with all these other factors. So looking at diagnosis and investigations, 50 to 70% of infants with CDH identified during pregnancy. This normally happens between the 18th to the 24th weeks of pregnancy on an ultrasound screening exam. And then polyhydramnios is associated in 80% of these cases. The ultrasound features include the polyhydramnios, intrathoracic fluid-filled bowel loops, an echogenic chest mass, mediastinal shift, and or intrathoracic stomach. Some markers of severity that Helga will go into further, but just to mention them here, if there's the observed to expected lung to head ratio, if the liver is up or intrathoracic liver, or mediastinal shift to the contralateral thoracic cavity, or if the baby has hydrops fetalis, these are all markers of very severe disease and has a poor prognosis. So fetal MRI can be done, and this will aid in diagnosis of diaphragm pathology, or if there's oligohydramnios or maternal obesity making ultrasound difficult. In the differential diagnosis, it's important to remember CPAM, bronchogenic cysts, bronchial atresia, or bronchopulmonary sequestration, as well as other mediastinal lesions, such as an enteric, neuroenteric, or thymic cyst, or diaphragm eventration. Then the accurate prenatal diagnosis and prognostication of disease severity is very important for prenatal counseling, as well as patient triage and planning of delivery, as well as in counseling for the parents and further genetic consultations. So postnatal, it primarily presents as respiratory distress, immediate profound distress at birth with acidosis and hemodynamic instability, or a delayed respiratory distress. It can present after 24 hours of life, or the child may be asymptomatic. Clinical signs will be increased respiratory rate, chest wall retraction, grunting, and cyanosis. On examination, you might notice a scaphoid abdomen, as seen on the right, with a subtle increased thoracic diameter. A cardiac impulse can be displaced, bowel sounds may be heard in the chest, and then there may be decreased air entry. Later presentations, if it's not such a severe CDH, they might present with mild respiratory syndromes, chronic respiratory infections, pleural effusion, feed intolerance, and then GIT pathology that's associated due to the malrotation of the bowel, such as obstruction or volvulus, or it may be an incidental finding on an X-ray for some other reason. Just lastly, coming to the end, looking at investigations, do an arterial blood gas will show hypoxemia with hypocarbia and acidosis, which may be compensated if it's not a severe defect. It's important to do this on the preductal limb, so the right limb, to get a correct measurement of what's happening with the baby physiologically. Then chest X-ray will show intestinal loops in the thorax, or a displaced nasogastric tube ending in the chest, as well as then the mediastinal shift. Abdominal X-ray may have minimal bowel gas. An echo is needed urgently within the first 6 to 12 hours of life. This helps to determine the degree of pulmonary hypertension, as well as to diagnose any cardiac defects. And then abdominal ultrasound is very useful to look at the positions of the different solid organs, as well as a KUB. Cranial ultrasound can be done to rule out any associated anomalies if the baby looks syndromic. And then further CT scan, MRI, and fluoroscopy can be used as needed. So just to summarize my part, as I mentioned in the beginning, it remains a congenital anomaly with 20 to 30% mortality, which is quite high, significant morbidity and long-term disability. There's a multifactorial embryological causes, mainly focusing around the herniation of the abdominal contents, the lung hyperplasia, and then the resulting pulmonary hypertension with a persistent fetal circulation. And then it also has that high association of other syndromes or other fetal anomalies. The 3 openings in the diaphragm that we mentioned, the different types that you can get, how to diagnose this in our country, and then the different presentations between both infant and child, and to go for diagnosis, arterial blood gas, chest X-ray, and ultrasound, and then echo primarily. Thank you from my side. Helga will look over prognostic factors, medical management, and surgical management. And those were my sources.
Kirsty, that was excellent. We will have comments after Helga's presentation, comments and advice. So what I feel is it's almost time for the first meeting to end. So I'm going to end the first meeting and we'll start the next meeting, and Helga will start talking in the next meeting. Okay.
Sure, Prof.
Okay, so I'm ending this meeting now. Helga, you can start sharing your screen, please.
Okay.
Okay. Yeah, I think just a few people are joining. Let's just give one or two more minutes.
No problem.
Okay, I think you can start, Helga.
Okay, yeah, Kirsty gave us a very nice introduction and where congenital diaphragmatic hernias come from and all of that. I'm just going to look at the prognostic factors. There'll be some antenatal, postnatal ones, medical management, and then surgical management, which is important for us. Antenatally, there's well, a few prognostic factors. One, we want to differentiate congenital diaphragmatic hernias from its differential diagnosis, mostly because they actually have a better prognosis than congenital diaphragmatic hernias, because they have better lung development and usually ventilate better than the severe congenital diaphragmatic hernias. The current gold standard for antenatal is ultrasound. Kirsty already mentioned it. There's two things we look at it. First one is the observed to expected lung to head ratio. This is done, or the lung measurement is done at the 4-chamber view of the heart. They measure the lung and then compare that to the head ratio. That is then compared to what is expected for the gestational age. Less than 25% is a poor indicator for survival, and depending on the parents and the counseling, often those children get aborted. More than a ratio of more than 35% has about up to a 90% survival chance, so that's a good prognosis. And then the second thing that we want to see on ultrasound is whether or not there's liver herniation into the hemithorax. If there is liver herniation, it makes it a more severe congenital diaphragmatic hernia with a worse prognosis. If there's no herniation, it's a better prognosis. However, on ultrasound antenatally, it's very difficult to differentiate lung from liver. So then the better option would be to do an MRI and to see what is the, well, to differentiate the two, whether the liver is up in the chest or not. and to measure then the total fetal lung volume, which is more accurate than the observed to expected lung to head ratio. However, that's not done in the majority of centers because it's difficult to come by. Then postnatally, well, one is the earlier the child presents with respiratory distress, the poorer the prognosis. The more severe the respiratory distress, also the poorer the prognosis. Red Cross in 1998 has come up with a formula to try and predict survivability. It looked at respiratory rate times PCO2 times FiO2 times the mean airway pressure, divided that by the PaO2 and divided by 6,000. If you have all normal values, it should come down, the number should be 1. If the result is more than 5, they have a bad prognosis. In their study, they showed that some children on the initial gas had a Red Cross ratio of more than 5, then however improved a bit, but then worsened. Those children also had poor prognosis, and so in the end they recommended that this formula is based on the first gas within 6 hours of delivery to predict prognosis. Then also, as Kirsty already mentioned, associated anomalies make for worse prognosis. She mentioned the pentalogy of control. The picture on the right gives you a bit of an idea of what it is. It is a congenital diaphragmatic hernia with a lower sternal defect, with pericardial defects, with a major cardiac abnormality, and then often an epigastric exomphalos as well. Then also, the more severe the pulmonary hypertension, the worse the prognosis. This is usually based on the increased right to left shunting, which can be seen very well on echo, which is why it needs to be done relatively early. Then another poor prognostic factor is an increasing CO2 and a decreasing saturation despite optimal ventilation. And next one would be hemodynamic instability. Often these children have a quite dilated right ventricle and an hypertrophied right ventricle with an underdeveloped left ventricle, which really makes it difficult to get adequate blood pressures. And then under debate whether or not it's a poor prognostic factor, but a lot of people quote it as poor prognostic factor is ECMO. We'll come back to ECMO in a bit. Then coming to the management of these children, it's a medical emergency, not a surgical emergency, as over the years we have learned. It's important to resuscitate the child, stabilize, ventilate them. I'll touch a bit on surfactant, then on the role of pulmonary vasodilators, inotropes, and that's where we come back to ECMO. It's quite complex. It involves a lot of things that all need to happen relatively quick to make a diagnosis and look after these children well. In the resuscitation and stabilization phase, we want prompt intubation with no bag mask ventilation, as that will just distend the abdomen that's already in the chest and make ventilation even worse. The current recommendation says we should start with conventional mechanical ventilation with as little pressure ventilation as possible. Then put in an NG tube as soon as the ET tube is in situ and secure to decompress the stomach and allow for some room in the chest. Then we want arterial and venous vascular access. Apologies for the gas, but we also want gases. Arterial access can be through the umbilical arteries. However, it's preferred to have it pre-ductal, like Kirsty has mentioned. So it would be nice to have a right radial ulnar artery access for repeat gases. And then also venous access, the umbilical vessels are nice, especially because we can put in a long catheter and then also measure central venous pressures, which I don't think we can do at Freya very easily, but that's what's recommended in the first world countries. And we do repeat checks of acid-base balance and oxygen. Our targets for ventilation is a pre-ductal SATs of 80 to 90, post-ductal SATs of 70%. We want to limit positive airway pressure to less than 25 centimeters of water. And we want to have a permissive hypercapnia up to 9.3 kilopascal, and some resources are found, some limited to rather around 8.5. But this is provided that the pH remains above 7.2. Since we have to juggle all of these, repeat gases will be necessary. Most important message, do not use too much pressure in ventilating them. The underdeveloped lungs cannot handle it. Then mechanical ventilation, we want to carefully ventilate them. Don't cause ventilator-induced lung injury. Pressure control mode is the optimal one, with rather increased respiratory rate and increased FiO2 over pressures. And peak pressures we mentioned is 18 to 22, but not more than 25. Previously, it was thought that a respiratory alkalosis would be better. However, that's been proven to be not beneficial at all. There's no role in increasing the PEEP to try and recruit lung. It's not recruitable. There's not enough alveoli and branching that had developed. And it's very easy to cause baro and volume trauma. So therefore, ventilate them with care. If normal conventional mechanical ventilation does not work, only then it's recommended from recently to use high frequency oscillator ventilation. And if that is not working, ECMO can be considered in the centers that have it available, usually in the first world countries. Surfactant has been previously advocated as useful. It was then studied in animal studies and was shown beneficial. So we had now reason that said surfactant is better, and animal studies. However, since then, it doesn't seem to improve outcome much at all. So currently a recommendation is to only use it in prem babies where we actually have immature lungs, and that might have a benefit. The reason we think it might be working is because small alveoli with not enough surfactant need a lot more pressure to open up and to ventilate. However, the alveoli in congenital diaphragmatic hernia children are underdeveloped, they're small, they might not be able to distend easily, they're still thickened, there's thickened blood vessels that surround it. So surfactant itself doesn't really increase ventilation because there's so many other things that are wrong at the same time. Then, because pulmonary hypertension is a very big problem in these children, the next thought was, well, maybe we can treat pulmonary hypertension with vasodilators. The one that's been looked at quite extensively is inhaled nitric oxide. It's a potent vasodilator. It's beneficial in a different group of patients, the ones that have persistent pulmonary hypertension or the neonate. However, through looking through a few studies, it's currently doesn't show any improved outcome in the congenital diaphragmatic hernia groups. There's an unpredictable response, and it seems to be very transient. And therefore, the current recommendation is to not use inhaled nitric oxide. Then people looked at sildenafil as another agent to possibly use. Phosphodiesterase type 5 inhibitor, which improves vascular remodeling, which hopefully does help the pulmonary vascular wall thickness that we already see. It has shown to improve oxygenation and the decrease in pulmonary vascular resistance. In the European guidelines, they currently say it can be used with close follow-up, and there's some studies going in to see if there's any advantage of giving it antenatally already. However, some have shown that there's increased, so this is currently under investigation. In terms of inotropes, which one to use when, we don't actually know. No study has been done so far to show which one of them is superior. As we previously mentioned, there's a common associated left ventricular dysfunction, and therefore the heart doesn't particularly pump well and often needs assistance. It's also why we need an urgent echo to see how good or bad is the heart right to left shunting, how good is the left ventricular function. And then as the next step, if the child is hypertensive, the recommendation currently is to give 1 20 ml per kg bolus. And if there's not much of a response or very transient response, to start inotropes. If we give more fluids than this, the child very likely goes into pulmonary edema, and the ventilation just becomes a lot worse, and we have not one at all. Therefore, currently the thought is to try and improve pulmonary hypertension, because that will generally improve overall blood pressures for these children. Then quickly looking at ECMO, it was initially, well, it's an extracorporeal membrane oxygenation. And it was initially used as a rescue therapy. It then evolved to be a way of preventing ventilator-associated trauma to these lungs of these children. However, it's very costly and not available everywhere. And after studying it for a couple of years, it still remains, children that need ECMO still remain with a poor prognosis, and its use and its advantage is currently heavily debated. Even in America, where money doesn't seem to be that much of a problem, the current thinking is that, well, the majority of patients that need ECMO are congenital diaphragmatic hernias, and they're the ones who generally die despite ECMO. They're therefore looking at whether it's actually worth it at all. There have been some recommendations in terms of contraindications, children that get excluded right away. These are the ones with significant congenital abnormalities or with lethal chromosomal abnormalities, like Kirsty had mentioned. Babies with a weight of less than 2 kgs, children with intracranial hemorrhage, and a gestational age of less than 32 to 34 weeks, as these already have a poor outcome. Then coming to surgical management, there's multiple approaches. The most commonly used is open, and out of those, the abdominal laparotomy approach is the most common and most recommended. There's a potential for a thoracic approach, but it's used rarely. In the minimal invasive group, there's again laparoscopic and thoracoscopic options. Thoracoscopic has been used, but currently the recommendations is to rather avoid it in neonates. It's better for older children. And then there have been a few studies that have looked at laparoscopic diaphragmatic hernia repair. I'll come back to that in a bit. And then the next big question is when to operate on these children. Initially, it was thought that the earlier we operate, the better. Clearly, if all the bowel content is in the chest, if we reduce that and fix the problem, their ventilation and all of that should become better. However, then we learned that their pulmonary hyperplasia is a much bigger problem, and therefore people have looked at what happens if we operate on later and compared groups of patients between 0 to 3 days, 4 to 7, and more than 8 days. and actually found that there was no difference in outcome between those, possibly even a better outcome for the ones that were operated on later. Next group of people looked at, while the child is on ECMO, is there any benefit from doing an earlier repair, which was defined as within 48 hours. However, there's no real consensus on that. They also have a higher risk of bleeding while on ECMO because they're on heparin and all of those. So overall consensus at the moment is to even wait until they're off ECMO before we operate. And recently, in the last 2 years, there have been drawn up a few guidelines to help delineate when must we go to theatre with these children, how good or bad must they be before we operate. And these were the ones that have been defined: a urine output of more than 1 ml per kg per hour, FiO2 of less than 50%, pre-ductal oxygenation of 85 to 95%, a normal blood pressure, lactate of less than 3, and an estimated pulmonary artery pressure of less than the systemic one. However, that's not available to us. Failure to meet these criteria within 2 weeks should prompt consideration of either attempted repair or palliative approach, and the same is true for ECMO. If they don't improve on ECMO, we need to make a decision whether or not to palliate or whether to repair surgically. Some centers say that, well, we got nothing to lose, so we might as well try and repair and see if that makes any difference. Others say it makes no difference, we're just wasting time and money, so I'd rather palliate these children. Coming to the actual approaches, the open abdominal approach is done through a left subcostal incision, well, mostly because the most common hernia is a left posterior lateral Bartholin hernia. Once the abdomen is entered, the abdominal content is reduced back into the abdomen. Usually then the hernia can be seen very well. The sac needs to be resected, especially in the posterior, in the Bartholin hernias. And then suture material, non-absorbable suture material is used. They recommend, especially if it's a larger hernia, to put the sutures without tying, and then once all of them are placed, to tie them. If the defect comes close to the ribs posteriorly, especially, the ribs need to be included in the repair. And if there's quite a large hernia, but there's a rim visible, it can be dissected out and freed, as it can aid closure, but it's not always easily done. As well, yeah, and then it's closed if there's any, if the defect is too big to close with just suture material, it might have to be reinforced or closed with a patch. Once that's done, as these children often present with malrotation and short mesenteric base, they might need a LATS procedure. And then chest drains, I'll come back to that, but they're not usually recommended. Then, yeah, the minimally invasive thoracoscopy approach is pretty much the same principles. It's just entered through the chest. The problems with this approach is that we need space to work in, but we already have underdeveloped lungs and pulmonary hypertension, so that complicates ventilation and hemodynamics further, especially while we try and fiddle. So, and these neonates generally have a higher mortality rate and higher complication rates. So currently not recommended for neonates. However, for older children, it might be a nice approach, as it might be less painful and less scars afterwards. But essentially, in terms of principles, it's the same. Once the chest is entered, the abdominal content is reduced, the edges are identified, and non-absorbable sutures are placed. again, if they have to go around the ribs to reinforce it. Then there are 2 South African cases reported that did a laparoscopic Morgagni hernia repair using a single site umbilical full thickness abdominal wall repair. I thought that was quite interesting. And they describe this because there's nothing so far otherwise that I can hernia repair with a single site abdominal umbilical approach. Other centers in the world have done laparoscopic hernia repairs. Interesting, in this one, they actually did not resect the sac, but just diathermic the edges to aid for scar formation to aid the repair, and placed non-absorbable sutures and sutured those to the abdominal wall to close the defect. Both their children were already older and relatively well children, and they did very well post-op. Seems to be a success for them. Then diaphragm replacements. The most commonly quoted one is Gore-Tex, but as a synthetic one. There are others also available, but majority of the literature seems to quote Gore-Tex, and most centers seem to use it. But there's also polypropylene meshes and other ones available. And then I've come across a mention of a split abdominal wall muscle flap. However, I haven't found much to say how it's done and how they secure it, how they dissect it out. But it's to try and reinforce it if it's a large hernia. And then something to keep in mind, because this abdominal content hasn't been living in the abdomen for long. If we do close the diaphragm hernia and then close all the abdominal content back into the abdominal wall, it might not have enough space. So you might have to put a silo or go to back. Post-op, some of the complications can be bleeding from the liver or spleen, especially if this spleen is stuck quite in the chest. It can be difficult and traumatic to reduce it. Also the liver, if it's a right-sided hernia. Trauma to the bowel can cause abdominal bowel contact to spill and cause peritonitis. Then one thing that's important to mention, a pleural effusion is expected in these cases, especially if the hernia sac is left in situ, but it's recommended we remove it. But even if it is removed, there's generally a space created that's initially filled by air, then later with fluid, and slowly reabsorbed over time. A drain is only recommended if this doesn't resolve. If a drain is put initially, these children often do worse because the fluid is drained too fast, causes major mediastinal shifts, and can easily cause pulmonary lung trauma, which we all want to avoid. Over time, the mediastinum shifts back to the midline, the fluid gets reabsorbed, and anatomy settles somewhere in a better situation. And then we watch and wait and hope for lung development, because as Kirsty said, that these children, or all children, still have alveolar development until the age of 8-9 years old. And then, as I mentioned, watch out for abdominal compartment syndrome. I'll come back to some of the long-term complications. Just a quick note on fetal interventions. It's been described as a fetoscopic endoluminal tracheal occlusion. It's done ultrasound guided percutaneous endotracheal placement of a balloon. It's placed around 32 weeks of gestational age and removed through the same procedure around 36 weeks. It shows some promise to improved outcome, but it can induce preterm labor, and is currently not current practice. It's still in being trialed, and the only people that can be enrolled in participating in a trial. So we'll have to see what the outcome of this will be. Outcomes for these children, Kirsty mentioned it already, different literature quite different mortality rates, but overall still has a mortality rate of more than 30%. There's a recurrence of the hernia in 5 to 15% of patients that will require another surgical repair. There's also very long-term neurological complications with neurodevelopmental delay and or many years screening for auditory problems. A lot of these children have respiratory complications long-term with recurrent infections, chronic lung disease, often need bronchodilatory agents for life. They also have quite a range of GI problems. Malrotation is one that we've mentioned previously, but because the anatomy is not all normal, they often present with gastroesophageal reflux disease that gets managed similar to any other patient who has GORD, but these ones end up more often with a Nissen fundoplication. They often have feeding problems and don't want to eat, and quite a few end up needing gastrostomies to be able to feed them. And they also have orthopedic complications with pectus and pectus carinatum and scoliosis, and might require orthopedic repair of those once they're a bit older. The scoliosis is more severe in the children that had quite big defects and needed us to include the ribs to be able to close the defect. So in conclusion, the outcome on these children depends on the defect size, whether or not the liver is up, whether or not there's congenital heart disease or any other associated anomalies. And then, as we see in a lot of our children, prematurity is also a poor prognostic factor. Congenital diaphragmatic hernias is a medical emergency, not a surgical emergency. Therefore, they first need to be stabilized before we take them to theatre. Important to remember is low pressure ventilation, which is a bit of a problem if we don't know that they do have a diaphragmatic hernia and get born and are hypoxic. But if we think about it, we have to keep that in mind. And delayed surgery seems to be better than early surgery. And this is, a huge, very complex topic with many controversies.
Helga, both Kirsty and you, it was really excellent. What we will do is we will end this meeting, and then I'll start the third meeting, and we will have comments and advice and questions in the third meeting. So I'm just going to end this meeting, and we'll start the third meeting in a second.
Sure.
I think all of us have joined. Both of you, excellent presentations, very good use of time, very nice resources you have read from, good understanding of the topics, and well presented. And I like the South African references as well. I will reserve rest of the comments for other consultants. Yashoda, can you start with your comments, please?
Sure, Prof. Evening, everyone. Well done, guys. That was really good. It is a difficult topic and there are a lot of controversies. So I think you did well to cover everything. So yeah, one of the controversies, like Kirsty was saying, is the cause. It's the chicken or egg scenario. So which comes first, the diaphragm or the lung? And generally now it's accepted that it is primary lung hypoplasia. That's the problem. And that becomes important when we see the children postnatally and we're trying to get them ready for theatre. So most of them don't make it to theatre, and this is an important thing that we need to keep in mind, is that most of them don't make it to theatre. And like Helga was saying, I would advocate for a trial of life, at least 48 hours, before you even try to take them, excuse me, to theatre. So the lung hypoplasia is the most important prognostic factor. Actually, pulmonary hypertension is the primary determinant of mortality for them. So it is a physiological emergency, not a surgical emergency. And we just, as surgeons, we need to keep that in mind, because it's very easy to fix the diaphragm, but you're not fixing the problem. So that I just wanted to make that point. And then also that the Morgagni hernias are not the same as the Börtele. Obviously, the anatomy is not the same, but also the lungs are not hypoplastic and they present later on. So their lungs are fine. So they do very well, unless they're part of ventralogy or Kentrell. Then, I don't know if, Helga, have you heard of Bones criteria?
No, I haven't come across that.
Okay, it's basically the Red Cross criteria that you saw. But Prof, do you remember Bones criteria?
Yes, I think Yashoda, those are probably going into disrepute now, because
I don't see why. Because basically, it is the Red Cross. It's
yes.
the PaO2. It's the PaCO2, the respiratory rate, the tidal volume. So I thought it made a lot of sense. So I'll try and find the book.
Yeah, there are different formulae, but I think Helga clarified what needs to be looked at. Now, I'm sure as an academic exercise, she needs to know about Bones criteria. But anything else, Yashoda?
Just to know about it.
Yeah. No, absolutely.
Yeah. It has gone out. They don't even put it in textbooks anymore. I'm not sure why, but I thought it was a good way to prognosticate postnatally, because you know how much the PaCO2 was, you knew how much the FiO2 they needed was, and then you can prognosticate based on that postnatally. So obviously the antenatal prognostic factors, you guys did very well in talking about those. So I won't add to that. Then,
may I answer you? Because I think, well, the Red Cross formula incorporates all of that to be more accurate than the Bones one.
Maybe they incorporated it and now it's gone out of, it's gone out of trend.
I think nowadays nobody is using any specific formula. I think you look at all those things, but anyway, continue.
So the antenatal screening, this is one of the pathologies that it's really, really important to us because of the antenatal counseling of the parents and the possibility of veto, which is developing, like you guys said. But because you said a 50 to 70% pickup rate, which I think it's much lower, especially in our setting. Yeah, I don't think it's even close to that in our setting antenatally. And then, but it's one of the most important ones, you know, for antenatal pickup, it's really important because the parents need to know that the mortality for these children is very questionable. This is one of the few, you know, antenatal diagnoses that you need thorough. Yeah, you might even need a surgeon to be involved with the counseling for these parents. And then for the management, Helga did well to describe that. So most importantly, no bag mask ventilation, because that is going to pop the other lung. And we see it all the time, these children with pneumothoraces. And then the surgery, yes. So laparoscopic, I mean, we would do it open from the abdominal approach. That's probably the easiest for us. But if we're doing minimally invasive, then it's probably better thoracoscopically because you can see better. And the abdominal contents just, you know, they go back into the abdomen, so it's easier to see. But otherwise, yeah, the resection of the sac, Helga, did you find any data on that, whether it's better or worse?
The current recommendation is that, especially in the Bartholin hernias, that it should be resected because it forms a reservoir for fluid collections and then as a space-occupying lesion in the chest again. That's the current recommendation.
Yeah, so that was the feeling, or that was what people thought a while back, is that the sac would continue to make fluid and then cause a problem. But as far as I know, we've gone away from that thinking now. But it's really up to the surgeon whether they will resect the sac or not. But there is a controversy.
One source mentioned it to use it as incorporated into your repair, to reinforce.
Yeah, you can even use the edges of the sac. So yes, I would say that, you know, it's not totally contraindicated to, I mean, leave the sac in. You shouldn't. It's not a rule to take out the sac.
Yeah, well, especially the Morgagni hernias, the ones that I've seen, not only the South African ones, but they left it inside with no issues.
Sorry, I just need to get comments from Dr. Majola and Dr. Lazarus as well. So Yashoda, if you don't mind, I'll invite now Kululeko. Yeah, Kululeko to make comments, please. Kululeko.
Hi, everyone. Thank you guys for a good presentation. My comments basically will be when it comes to just a few clarities. The last sources or what I've read was that we still need to excise the sac.
Yes. Not
really related to it still forming any fluid or collection per se, but that sac is also a weak spot if you incorporate it into your repair. So that's why you need to really find that edge of the muscle and unroll it. If you can't, then you need to incorporate the rib as your anchor for the repair. And also with thoracoscopic, if you're using minimally invasive, initially they thought that using thoracoscopic, it will be easier because your insufflation is gonna help you to get to push the content back into the abdomen. But once the pressures equalize between the abdomen and the thorax, then it becomes difficult because the content pops back up into the thorax. Then it becomes a tedious exercise. So you really need to work very fast if you're gonna use thoracoscopic as your means of closure for that repair. But also, that being said, there's a higher recurrence rate if you use minimally invasive technique in closing these hernias. So just a few questions to Helga. You looked at the imaging or the when you do your ultrasound or your other imaging as prognostic factors, what did you find as the parameters that they used when you're looking at your lung head ratios? So I just want the figures. What did they use as a good prognostic factors or good prognostic number and bad prognostic number? And also, what's the difference between the ultrasound and MRI? What do we look for when we're looking at the prognostic factors?
So on the ultrasound, you want to do, the
Helga, you had that nice slide.
yes, I'm pulling it up.
Yes,
Well,
ultrasound.
I'm have to try and get it back onto sharing.
Maybe Dr. Bajola just missed that slide because you had that slide.
Oh, maybe I did.
Yeah, no,
I'm trying to put it back up here.
no, that's there. Yeah.
Okay. It has, so they looked at the observed to expected lung to head ratio. The lung diameter was measured at the, no, it's actually not the diameter, it's the outline of the lung was measured at the 4-chamber heart level. And that compared to the head circumference. And that is then compared to what do you expect for the gestational age of the baby. And then you compare observed to expected ratio. And if you have less than 25% of that, you have a poor survival. And if you have more than 35%, you have quite a good survival, up to 90% survival of those children.
One more thing, did you find anything related to esophageal occlusion prenatally, and what were the sort of pronounced advantages of performing that procedure in the patient with this condition?
So if you do a prenatal tracheal occlusion, initially it helps to proliferate the growth or the branching of the bronchioles. But if it's not removed early enough, it prevents them from forming surfactant and maturation of pneumocytes type 1 and type 2. So it actually has to be removed a good week or two before they deliver. Otherwise, we have another problem. But I'm trying to think where they'd seen it in animal studies where they had tracheal atresia and stuff, and that's where they came up with that idea.
Yeah. So the thing is so when you do ultrasound, you're looking at the lung head ratio, but when you do MRI, you're looking at the volume of the lung. So yes, what they're trying to do with esophageal occlusion is they're trying to increase the volume of the lung, but it doesn't help with further differentiation of your divisions of the lung. So it doesn't really help, but it increases your volume because you're retaining the fluid that is excreted by the lung by blocking. So the hypoplasia itself doesn't improve. It's just that your size of the lung improves, and then it gives you a notion that your prognostic is going to be good with the esophageal occlusion. But in fact, in itself, it doesn't help because the important structures of the lung are not formed. So it doesn't really do much in a sense.
Okay, I haven't come across that. I've only come across the initial thinking of why it might work.
I think you meant tracheal occlusion, Kululeko, isn't it?
Yes.
Yes, tracheal occlusion.
Yeah. No, he explained it very nicely, Helga. that just the volume increases, but not the maturity. So that's very nice explanation. I hadn't heard it before. Very nice. Anything else, Kululeko?
Yeah, just the other thing that they were going through with your parameters. So I think it just depends on which center and what they decide to use as their own sort of when the patient is ready. So oxygen index was, I think, was a good sort of investigatory laboratory or marker to see if the patient is ready or good or not for theater, because you're looking at your O2, you're looking at your CO2, and what else? Because every center has their own thing. So the Red Cross one also, they use their own thing, but oxygen index is also a very good sort of marker, and it's a simple formula because you're looking at mean arterial pressure, oxygen, FiO2 with the O2 patient. So if it's less than 6, then it's a good prognosis because that means the usage of oxygen by the lungs is good. But if it's greater than that, then it's a bad prognostic. And there's also other ones that they also use, alveolar arterial oxygen gradient, which is also a simpler formula to use than what I've seen other centers use.
Okay.
Helga, are these guidelines from up to date?
No, they're from an article that was published in 2018 that compared Canadian and European guidelines. They have quite a few recommendations about what should and shouldn't happen, backed up with evidence that we have at the moment.
Yeah, no, but I think what Dr. Majola is pointing out is to what is given in our books as well. So I think you better just know about that.
Yes.
Okay. And Kululeko, anything else? Otherwise, I want to get Dr. Lazarus to comment.
That's all, Prof. Thank you.
Okay, thank you, Kululeko. Colin, what comments, advice can you give?
Thank you, Milind. And again, thank you for the very, very good presentations of the physiology, the pathophysiology, and our approach to management. So what I'd like to just take one back is not onto too much in the sense of detail, but aspects of management, in particular the medical management. And these are the thoughts that I have. First of all, I'd like to say that I don't think the mortality that I've observed both in the public and private sector has been that the majority of our patients die.
Mm.
In fact, I would think that the majority of our patients do survive. And I think that probably is in line with experience in other places in the country. I hope I'm right about that. But it seems to be seems to me that that's the case. What I would have liked to have heard, Helga, a little from you, was not only all the modalities of management which are available, but more particularly how you would manage a patient in the ICU situation. Patient has been born, the diagnosis has been made, the nasogastric tube is in, the endotracheal tube is in. How would you now manage the patient? Because certain of the things that were drummed into me, like keeping a quiet environment, making sure the baby's not in pain, doing what you can to avoid shall we say, metabolic acidosis. So no, that's not the primary source of acidosis in that baby. Bearing in mind that there are two bad things. One is barotrauma, and the other is pulmonary hypertension. So what ought we to be doing? But what we do have, we have. And we need to know just precisely what each of us would be doing when faced with being the person responsible for the management. That, I think, is what is important. I think that's basically what I wanted to say. One more thing. We can't overcome the lung hypoplasia if it is too bad. Perhaps 1 out of 3 patients have to die because their lungs do not have sufficient alveoli to survive. And perhaps 1 out of 3 will survive even if we manage them less than optimally. But those 1 in 3 in the middle, we have got to manage absolutely expertly if we're to get them to survive. And we as pediatric surgeons can't abdicate that responsibility to our colleagues in pediatrics, who might be less experienced than we are at nighttime, etc. Enough for me. Thank you.
No, thank you very much. I think that is very important. So I think, Helga, that's very practical advice is, we were told to keep these patients in a corner, preferably not too much noise around them, and minimal interventions like do blood gas only when it is necessary, and adequate pain control, etc. So those are the practical things which we need to follow, and we should not depend on a junior pediatric medical officer about management of the blood pressure and the ventilation, etc. And just one small thing which I think you can include is the patch. One is you mentioned Gore-Tex, but the other patch which I would like to hear the name is Surgisys, which is a composite patch, but that's just a very minor thing. And post-operative complications, then you could have included that those who have patch repair have obviously more chance of recurrence of the hernia. But I think overall the presentations were very good. Neha, do you want to make any comment, want to ask any question for advice from the consultants?
No, Prof. Nothing to comment about.
Okay, excellent. Anybody else wants to ask any question? Otherwise, these presentations were excellent, high quality, and really nice attending to. I see Dr. Delgado is here. Arturo, do you want to make any comment, please? Arturo?
And here. Now, what I want to thank for that nice presentation. That it's very important. Also, thank all of you to give me the opportunity to be this here with you. Greet to everybody.
Okay.
And emphasize the issue that the patient with a diaphragmatic hernia is not a completely total emergency at the particular time. We need to take time to stabilize. And when I say time, sometimes it's 2-3 days.
Yes.
We have to arrive to a near stabilization of the blood gases. Otherwise, everything that we do, we're not going to have good result. I remember the time, as you remember when the younger, diaphragmatic hernia rushing in the middle of the night to theater.
Correct.
very bad result.
Yes.
So I wanted to emphasize that. And thank you very much again.
No, thank you, Arturo. Thank you for your presence and contribution. I think if there are no more comments, then I would like to close the meeting. I just see there is something in the chat. Kirsty is asking, how many have you seen at Frere that were operated on? Kirsty, I wouldn't have offhand statistics on the tip of my fingers, but what we, Dr. Lazarus and I believe, and I'm sure other consultants will agree, that many of them probably die in periphery. They just present with respiratory distress, and nobody does a chest X-ray, or before a chest X-ray is done, the child dies. And so quite a few of them don't reach us. Those who we are able to stabilize and able to operate after 2 days, 3 days, I think they have done well. And some of them during trial of life, they have not come to theater, they have just died. So we will just have to look, but unfortunately before 2019 we won't have easy access to statistics. So we will be able to find out how many we saw last year and this year, but I can't give you exact figure. Okay.
We've only seen one this year, to my knowledge, that didn't make it to theatre. That child only lived for about 12 hours.
Right. Yeah, so again, it is not an uncommon problem. I think the incidence is something like 1 in 5,000. That means it is almost similar to anorectal malformation. So the very fact that we don't see as many is because they don't come to us, they just die in periphery. And those ones which are very mild, they may not even present because they just have respiratory distress. Somebody sees some lesion on the chest X-ray, gives TB treatment, and they just keep following. So they may not come to us at all. But I think if there are no more comments or questions, then I will close the meeting. Has anybody else got any comment? Gerard, anything?
Grandpa will get cross with you.
Okay, I'm going to close the meeting. Thank you very much. Everybody will see you next week.
Thank you.
Bye.
Bye.